Hi, welcome to this week's live show brought to you by American Acupuncture Council. I'm your host for today, Poney Chiang, coming to you from Toronto, Canada. I'm a continuing education provider, and if you like more information about me, you can find it on the title slide. Today, I'm going to talk to you about strategies for dealing with neurological complications or neurological symptoms as a direct result of patients that have unfortunately been afflicted with COVID-19. And there's actually a growing amount of literature in this area. And since my interest and expertise in the area of neurology and acupuncture, naturally, this is an area that I'm very passionate about. So I'd like to show you some of the readings and research and strategies that I've applied in my own clinic. The first paper that we're going to look at comes to us directly from Wuhan, and this paper was published in just March, and it's a retrospective observational study conducted from 3 different centers. So these patients were tested positive for COVID in the month of January and February this year, and there were a total of 200 plus patients, and they were all assessed by neurologists, and their neurological manifestations were categorized into 3 different subtypes. The first type is called the central type, and the central nervous system type gives you symptoms such as headache, impaired consciousness. You can have an acute cerebral disease or cerebral vascular disease. That's another word for stroke, and you can have ataxia and seizures. The second type of classification is peripheral nervous system symptoms. And the most famous one that you may have already heard about is lack of smell or lack of taste. And sometimes it can be vision-related impairment as well. The third type of dysfunction had to do with skeletal muscle injury. So patients would complain about pain. Those of us that know people do have been infected with COVID would tell you it's like a flu that you like none other. You just hit with it, your entire body hurts. I even had a friend tell me that it feels like shards of glass in his joints. That's how painful it is. Okay, so those are the 3 main neurological classifications, and as I said, this is a study of 214 people, and what the research found was that 36% of these patients all exhibited neurological symptoms. And what was interesting is that those with more severe infections, defined by having more poor respiratory status, which was in this case 41% of the patients in this study, they were more likely to develop neurological problems. So somehow, the harder you're being hit by this disease, the more likely you're going to have neurological symptoms. And just to have a breakdown of roughly the proportions of the 3 different classifications I mentioned, about 25% of these patients had central nervous system symptoms. About 10% of the patient had peripheral nervous system symptoms, and another 10% or so have musculoskeletal symptoms. So you can see why this is something that we as acupuncturists should be aware of, because oftentimes patients with CNS and peripheral nervous system, and of course muscle-related problems, want to come to us for support. Of the central nervous system symptoms, the most common ones were headache and dizziness, whereas in the group for the peripheral nervous system, the most common symptoms were impaired taste, which is called ageusia, and impaired smell, which is anosmia. And a patient who had muscle injury, as compared to those who had no muscular pain symptoms, were found to have higher C-reactive protein levels and higher D-dimer levels. C-reactive protein is a marker for systemic inflammation in the body. So patients who have more inflammation in the body was more likely to have muscle pain. And D-dimers is a breakdown product that the body makes when blood clots have been broken down, which is indirectly a measure of how much coagulation there is in the body. So in other words, those with more coagulation, think in terms of blood stasis and TCM. Those with more C-reactive protein, indicative of inflammation, think in terms of blood heat in TCM. These patients are far more likely to develop muscle injury-related symptoms. Now, I want to emphasize that neurological symptoms is not just limited to the central nervous system. We mentioned there's the peripheral and there's the musculoskeletal. So I don't want you to have an impression that stroke COVID patients are all being afflicted with strokes. Okay, that was the picture that was being passed around in the early stages when we didn't know what was happening. But now it seems to be that uh, uh, they are more likely to develop central nervous system symptoms such as acute cerebral vascular disease, like stroke, but it's not the entire spectrum of neurological symptomologies that these COVID patients have. So, as an example, in the Wuhan study, okay, there are six patients out of only 200, only six patients out of 214 had acute cerebral vascular disease. And two of them actually arrived at the ER with sudden hemiplegia, paralysis, weakness of one side of the body, but they did not have any COVID symptoms. That is to say, no fever, no cough, no anorexia, no diarrhea. And they were only found to be suspected of having COVID from CT scans of the lung that found there's some lesions. And then they were subsequently tested with PCR-based assays to confirm that they had indeed were infected with COVID. So this is important because one need to realize that patients may never have gone to the hospital, okay, because they're afraid of going to the hospital because they don't want to go get contract COVID in the hospital. They may have neurological symptoms and they will go to the community for care, even though they are positive and not, because they, but being asymptomatic positive. Another interesting finding was that some patients that did present with fever and headache, okay, were presented to neurology ward in Wuhan, and they were initially positive negative. So either the viral titers weren't high enough to be detected by the assays, or it was a false negative. And then only when the symptoms really started to come on, like coughs and the dyspnea, then they were retested to found to be positive. So that's important to keep in mind as clinicians, that we need to be aware of possibility that patients come to us with neurological symptoms, but may actually be symptom negative, but in fact positive COVID patients. So in summary of this, from this paper, they found that all the patients that had neurological problems tend to have lower lymphocyte counts, white blood cell counts, which is indicative of some level of immunosuppression, and therefore they are more likely, for mechanisms that scientists are still starting to study, more likely to be afflicted with central nervous system symptoms. And now patients who have more severe infections, meaning worse outcomes with the respiratory integrity, had higher D-dimer levels. That again, it's a measure of how much coagulation there was in the patient's body, and this can explain why those with more severe infection, meaning more worse lung function, having more D-dimers, are then more likely to develop occlusion or clot type of strokes. The important reminder that the authors of this paper wanted to share with us is that, I put this in red in quotation, that during the epidemic period of COVID-19, when seeing patients with neurological manifestations, physicians should consider the COVID-19 infection as a differential diagnosis in order to avoid delayed diagnosis or misdiagnosis and prevention of transmission. So this is an important wisdom for all of us to take to heart as practice start to open and you're seeing patients with neurological issues. You might want to gently remind them to go get tested because it's a possibility that they could be positive and just be asymptomatic. Now, a group in Spain replicated this type of study, and but this time with a larger n size of 841 patients. And this time around, with a larger sample size, they actually found that close to 60% of patients of COVID-positive patients now presented with neurological symptoms. And this was data collected across two different institutions. And however, okay, I don't want to be an alarmist. Not all neurological symptoms associated with COVID are stroke. Okay? If you look at these numbers here, only 11 out of 840 actually presented with ischemic the ischemic stroke, and 3 presented with hemorrhagic stroke. So that's only 14 out of 840. Right? The mean time of occurrence was approximately 10 days after the development of the COVID symptoms. So they started having stroke 10 days later, after presumably having cough, dyspnea, fever, and as such. And again, there was a very strong correlation between those that who had the stroke, in other words, the cerebral vascular disease, and those with higher D dimer levels, meaning that's the byproduct of the breakdown of clots in your body. So in other words, no surprise, more clots in the body, more likely to have a stroke presentation. Now we're looking on this slide. We're looking at a paper published in Germany. Okay, and this paper was attempting to summarizing the amount of ischemic stroke that was being seen in patients with COVID from 3 different countries. From, as in the first column, you can see from the United States, second column from China. And so this China column is actually the paper I just presented from Wuhan. Okay, and then another paper which I'm not presenting today is an N size of 206 from Singapore. Okay, and what I wish to point out, okay, is that you can see the number of people having strokes in relation to the total positive number of COVID patients. It's relatively small. Okay, now they all have associated risk factors that we know of, being hypertensive, being obese, having diabetes mellitus. These all predispose you to more higher incidence of infection in these diseases. And what these researchers have found was that in the overall picture, if you look at the type of stroke, okay, that is being that the patients are having, there is a preference or a more heavily weighted manifestation of large artery occlusions, in contrast to small vessel types, in contrast to blockages in the heart or cardioembolisms. Okay, so even though the number of strokes that COVID patients have is not very high, it really depends on the severity of the infection, and it depends on how much D dimers they have. If they were to get a stroke, based on the limited amount of data we have to date, it appears that there is a preponderance towards large artery occlusion type. Okay, and now let's take a look at the outcome of these patients. In China, okay, of the 11 people that had stroke-related presentations, 4 of them died. In Singapore, of the 5 people, 3 of them died. In the United States, none of them died, and they were then subsequently sent to ICU, stroke units, rehab, or when to go home. So we can potentially, as acupuncturists, be seeing these patients that are being sent back to the community for rehabilitation purposes. Now, I want to talk a little bit more about this large artery ischemic stroke. This paper that was talking about the 5 people from the United States is summarized in this tabulated form in the next slide. So this is a paper that was published in the New England Journal of Medicine. Okay, and this is physicians in New York were noticing that wait a minute, like young people are getting strokes. This is not expected. So if you look at the first row, you can see the patients 1 through 5. These are patients that are under the 50s. Most of them actually in their 30s or early 40s. Young people should not be getting stroke. Okay, so even though, okay, I said repeatedly that strokes are not the most predominant type of neurological symptoms in patients with COVID, it is kind of sad and devastating that these can affect young people. Okay, so and not all of them had the risk factors we talked about, such as hypertension and diabetes. Look at the third row here, medical history and risk factors for stroke. It was none. These people, none. Okay, undiagnosed. One of them has undiagnosed diabetes. Okay, and some of them have hypertension, but some people had no symptoms whatsoever. A lot of them weren't even on any medication. So relatively healthy people, young people, can get this. So another thing I want to bring to your attention is look at the symptoms that these patients present. Okay, so they present with hemiplegia, loss of consciousness. They can have difficulty speaking. Okay? They can have altered sensation. They can have something called gaze preference, issues to do with the eyes. We're going to go, and also hemianopia, which is also a vision-related symptom. We're going to talk a little bit more about the visual aspect of stroke and have some strategies you can deal with that in the upcoming slides. If you look at the vascular territory, the ones that are the strokes involved, you'll see that it is affecting the internal carotid, okay, affecting the middle cerebral artery. Okay, most of them are affecting the middle cerebral artery, with one exception here is affecting posterior cerebral artery. So what I'm going to also talk about that. It means that patients that have stroke, these large vessel type of strokes, tend to be getting it in the internal carotid and its derivatives, such as the middle cerebral artery. And let's look at the symptoms of these patients, right? So some patients have cough, headache, and chills in the first column. Okay, patient 1. Patient 2 has no symptoms. Okay, patient 3 had no symptoms. Patient 4 was just tired. That's it. Other than that, no fever, no cough. Okay, so this is how I want to just stress upon you. Maybe you want to take this into consideration when you screen patients, whether you accept these type of patients in your patients are in your clinic or not. If somebody comes in with neurological symptoms needing help, and this developed in the last 2-3 months, it could very possibly be COVID, asymptomatic COVID patients who've had this, and they've never had a reason to go get tested because they had no symptoms. So it's up to you whether you want to open up your clinic to help these type of patients, or maybe request a testing before that you're able to help them, etc. Okay. So a little bit more about this large occlusion, artery type of occlusion. What is it exactly? It results from embolization, okay, of atherosclerotic debris. So think about plaques inside your blood vessel. And embolization means that these plaques have become free, dislodged. Okay, and usually they originate from the common or internal carotid artery in your neck. The common carotid artery divides into internal and external. I'm going to show you some pictures about that in a moment. Sometimes they can actually come from the heart itself, the vessels of the heart itself, and they become dislodged. And then the large vessel ischemic strokes that develop are most likely to affect the medial cerebral artery territory. In other words, the symptoms, the neurological symptoms the patient are going to manifest are going to be whichever part of the cortex that the medial cerebral artery supplies. Okay, so this is why it's important to know the anatomy. Knowing which part of the vessels are more likely to be affected by in COVID stroke type of patients, we can then predict what is the most likely type of symptoms or neurological dysfunctions that these patients are going to have based on the vascularization of relevant function area, corresponding functional areas in the brain. So this is just a quick review of the circulation of the brain. What you're seeing here is in the center is the circle of Willis that we all learn about in school. What I love about this slide is that they color-coded it such that in purple, okay, are called the posterior circulation, and it's called posterior circulation because it comes from the vertebral artery in the back. Okay, if you look at the patient on the right side over here, VA stands for vertebral artery. And whereas the green shade called the anterior circulation, okay, which subsequently divided into anterior cerebral, and medial cerebral, okay, and then also IC stands for internal carotid artery. These green ones come from, okay, as you color coded over here, comes from the common carotid artery, which divides into ECA. CCA is a common carotid artery, which divides into ECA for external carotid artery. This goes on the face, okay, outside your skull, and then the internal carotid artery, okay, which as you can see is now green, and then goes into the brain and divides into anterior and medial carotid artery. So here is the picture of the internal carotid artery label over here. This big one over here in green, the biggest one, the biggest cross section in green, and you can see it divides into anteriorly the anterior cerebral artery, ACA over here, and then as going left and right laterally, this one here is the medial cerebral artery. So patients are most likely to have clots in here before the division, or somewhere in the neck here, okay, or after the internal carotid has bifurcated into the middle cerebral artery, you can have occlusions in the middle cerebral artery. So now we're going to take a look at where the middle cerebral artery supplies. So this is a very nice picture that shows you in a color-coded manner different areas of the brain compartmentalized based on its source of vascularization. So in the bottom here, on the bottom here, you can see A, okay, this is turquoise color, A part. These are all supplied by the anterior cerebral artery, okay, it's not relevant to our discussion here. All the P part, or the red parts, are all supplied by the posterior circulation, okay, that's also not relevant to what we're talking about here. All the yellow ones, okay, labeled N, shows us where the middle cerebral artery supplies. So as you can see, it supplies a large portion, okay, of the lateral surface of the cortex, both the frontal, the parietal, and even the temporal lobe. Okay, so it is a very important area. If you look at the cross section over here, you can see here's the internal carotid artery, and then it divides into this tiny little guy. Here's the anterior cerebral artery, and then divides into the common carotid artery. So the patients with COVID are most likely having large vessel strokes. What that means is that most likely causes in here before the bifurcation, or in here in the middle cerebral artery. Why is that not in the anterior? Because the anterior is small, so therefore it doesn't qualify as the large vessel type. Okay, now as you can see, the middle cerebral artery then divides and wraps upwards to cover the parietal lobes, and wraps downwards here to cover the temporal lobes. And so here's a side view on this side here. Very beautiful picture. I love this picture. And you can see that if the occlusion is happening in the common carotid or medial cerebral, then all of these arborizations are going to be shut off. And that means all the neuro-cortical areas that are in this region are going to be hypoxic, and therefore going to show dysfunction. Now, what's in this area? If you remember your scalp acupuncture, there is the sensory line and the motor line, and that's all relation to the central sulcus, right? So where is the central sulcus? The central sulcus is in here, okay? There's the most prominent sulcus over here. So anterior that to the motor, posterior that is a somatosensory. Now, so this means that somebody who suffers with middle cerebral artery stroke is going to have sensory motor dysfunction, okay? And even though the medial part, which is the blue A part, okay, this is the region that's more like where the lower extremities are located, even though it is not part of the middle cerebral artery distribution, there is some overlap. So you can still expect patients to have lower extremity problems. And I'm of course referring to the homunculus map on along the central sulcus, where if you recall, the medial 1/5 is supposed to be the lower extremity, the middle 2/5 would be the upper extremity, and the lateral 1/5 would be the face. So let's approximate that on the picture here on the top right. In this area over here would probably be the lower extremity. Around here would be the upper extremity, and when you get down to the part closer to the sylvian fissure over here, which separates the parietal lobe and the temporal lobe, you're going to get close to the facial areas. Okay, so these patients can obviously expect facial drooping, facial motor deficit, upper extremity, and to some extent lower extremity also. Now we're going to take a little segue now and talk about what other things are involved other than just the occlusion. Right? There's something that is called SIC, which stands for sepsis-induced coagulopathy. Okay, so that means it's a coagulation or blood clot that's induced by having a blood-borne infection. Okay, and then scientists now know how the virus gets into our bodies through a type of receptors on certain cells called ACE2 receptors. ACE stands for angiotensin converting enzyme. Okay, and these type of cells are found on lung cells. So no surprise, COVID is primarily an upper respiratory airway disease. Okay, it's found in small intestine. Okay, so perhaps I can explain why some patients have gastrointestinal symptoms with this disease. It's found on endothelial cells, meaning these are the lining cells of your blood vessel and your lymphatic system. So now we can see how it's actually can attack the vascular system and leading to cerebrovascular events. And it's found in smooth muscles in the brain. So no wonder people can develop neurological central nervous system symptoms as a result of this infection. Now, I'm no expert about the complicated receptor cascade that regulate the inflammation and coagulation in the body. So I'll just summarize it for you. ACE2 type of receptors are known to activate cardioprotective or neuroprotective effects inside the body. Now, when COVID-19 infects us through ACE2 receptors, it depletes the receptors. So meaning whichever function that these receptors are supposed to do physiologically are no longer can be accessed. So what this means is that our body is in a lesser, more compromised cardioprotective and neuroprotective state, leaving ACE1 type of receptor to act unopposed. Think about yin and yang regulation. Okay, so what was ACE1 activating? ACE1 type of receptors ultimately results in cascades, signaling cascades that activate genes that lead to inflammation and coagulation and even hypertension inside the body. Okay, so as the coagulation is not bad enough, now you have high blood pressure, you're more likely to cause a stroke, right? So it is because this virus has the taste for ACE2 receptors that is supposed to be neuroprotective for us, but as a consequence of these receptors being also found in the brain, okay, it's a double whammy. You are now set up for inflammatory and coagulatory disaster. Now, scientists are proposing different ideas of how this can lead to damages to the brain. We now know that there is more inflammation in the body, okay, because of the unopposed ACE1 cascades inside the body. But what that inflammation does is that it can actually lead to damage, okay, or breakdown of the blood-brain barrier. So the blood-brain barrier is a very delicate piece of barrier inside our body, and if it is broken down because of inflammation, that spells doom. Okay, what happens is then now the inflammatory cytokines in your body now can cross the blood-brain barrier and reach the central nervous system. So it's just bad on top of bad. Okay, so now you may have heard about cytokine storms that happen in this patient. Is actually your body's immune response that is actually hyper immunity response towards the virus that is actually causing damage to tissues and organs. That is certainly can also affect the brain now because it's causing breakdown of the blood-brain barrier. So I think that's really interesting information about the neurophysiological mechanism, how this virus affects us, and gives us a good epidemiological appreciation of how this disease can manifest in neurological ways. Now I'm going to share with you some of my ideas about how we can help these type of patients using areas of my research that I've done about the peripheral nervous system and the central nervous system. This is a map called a Brahman area map, where the different parts of the brain have been compartmentalized based on different functions. I share that here just as a quick reference for you because in my upcoming slides, I will be talking a little bit about some of these areas. Okay. So one of the most common peripheral nervous system functions was anosmia, which is loss of smell, and ageusia, okay, or hypogeusia, which is loss of taste. So how can we possibly help patients with this? First of all, we need to say that cranial nerve 1, which is the olfactory nerve, is way deep inside the brain. It's not accessible. And unfortunately, the olfactory cortex is also not accessible. It's not close enough to the surface of the brain for us to be able to affect it through scalp acupuncture. If you go back to the previous slide, you'll see that olfactory is a dark orange. The dark orange is actually area 34. Okay, so that if you see this is actually in the midline. This is the lateral surface. This is the midline. So it's actually on the inside of the temporal lobe. It's not accessed too far in for acupuncture to possibly reach us. So what can we do? Okay, fortunately, okay, we have points that have been passed down that are supposed to have some effect on the nose and sense of smell. That's over-located on the midline of the scalp. But let's take a look at the neuroanatomy and see if it actually makes sense based on what we know about the neuroanatomy of the nerve supply for the nose. I wanted to talk about the anterior ethmoid nerve, okay, which is actually from the ophthalmic division V1 of cranial nerve 5. Okay, and let's take a look at that. So anterior ethmoid nerve, here's the ganglion of the trigeminal nerve, and there's your V1, V2, and V3. So as part of the V1, you have this nerve here that branches into the posterior ethmoid and anterior ethmoid. See how it goes, it makes a little hole in the foramen in the back of the eyes. So from here, it goes into the cranial vault. I'm going to give you a different view at the next slide here. So it comes out these foramens over here. And these nerves actually supply the meninges. So here's the anterior meningeal branches and anterior ethmoid nerve. Okay, it supplies the meninges. But because this cross section is horizontal, okay, I want you don't appreciate how high up this innervation goes. So this next picture shows you that the ophthalmic division of V1, okay, and specifically the anterior ethmoid nerve, innervate this bony membrane called the falx cerebri along the midline, okay? And so it gives credence to the notion that these points that have been passed down to us go about 20, okay, all the way to 23, 24, which is on the midline, which is innervated by the anterior ethmoid nerve, can possibly affect this nerve. Now, so what's the big deal about affecting these nerves? Well, this anterior ethmoid nerve not only just innervates the meninges, these same nerves are branches that innervate the nasal cavity and septum. So as you can see here, the anterior ethmoid nerve, after it innervates the meninges up here, comes very close to the olfactory bulb, by the way. So we currently don't have information to confirm this, but normally what we know about the nervous system, oftentimes there are communication branches that might be able to affect the cranial nerve 1 olfactory nerve. But even if it doesn't, this nerve, okay, has an external branch that goes outside to cover the skin, but an internal branch that innervates the septum and also the nasal cavity. So this nerve gives information about the amount of mucus or dryness there is in the nasal cavity, and presumably your nervous system can regulate the amount of moisture in your cavity. And we know that dry nose is related to mucous membrane is needed, moisture is needed for fragrance particles to adhere, and therefore more likely for us to detect the smell. Perhaps by modifying the internal conditions of the nasal cavity, even though we're not affecting the cranial nerve 1 directly, we are making it more favorable for the cranial nerve 1 to actually be able to detect smells and fragrances. I thought it was just pretty crazy that these points that we learned on the anterior aspect of midline of the scalp to do with the nose actually has hard cranial nerve related explanations for how they can affect the nose. Now, we talk about taste, okay? The gustatory cortex is something that is accessible. So the gustatory cortex is actually Brahma area 43. It's a tiny, tiny little area, basically at the junction of the Sylvian fissure, okay, and the central sulcus. So you can see here, this part here is the central sulcus. So anterior to that is the motor, posterior is the somatosensory. If you continue all the way down where the motor, sensory, and the temporal lobe meets, that's Brahma area 43, which is the gustatory cortex. And based on the MRI research that I've done and talked about elsewhere, we have a chance to affect this area, but it requires a special kneading technique called the cross-threading technique, where you would thread down from gallbladder 5 and thread anteriorly from gallbladder 6, and that would allow you to cross-intersect over Brahma area 43, which is the gustatory cortex. So if you review the vascularization of the middle cerebral artery and with the parts that it affects, you can see why it would affect the taste, because that's the gustatory area is part of the middle cerebral artery domain, and therefore can explain why patients with COVID may have loss of taste if they develop central nervous system type of symptoms. Now, another way we can possibly affect the taste is using nerves called the lingual nerves. Okay, and these lingual nerves are branched of the mandibular division of the trigeminal nerve. So remember, the trigeminal has 3 divisions. The mandibular is V3. Now, even though this is strictly speaking, again, a sensory nerve, okay, it is not responsible for taste. In fact, the taste of the anterior third of the tongue, as the comments here are written down for you, is supplied, okay, by the facial nerve, okay? So the sensation is supplied by the lingual nerve, but the taste, special sense taste, is essentially by the facial nerve. However, the facial nerve relies on the lingual nerve to convey its nerve fibers back to the brain. So this is the reason why patients who have damage in the lingual nerve, either due to dental procedures and whatnot, can oftentimes cause them to feel like there's metallic taste in the mouth, or a foreign taste, or lack of ability to taste. And so fortunately for us, we have acupuncture points located right below the tongue to affect these lingual nerves, and that's the extra points, Jing Qing and Yu Ye. So puncturing these points, even though it doesn't affect the special sense directly, it provides conveyance of the special sense nerve fiber back to the brain, so which might be able to help to receive more signal about taste to the brain. Now, early on, people also published oculomotor dysfunctions associated with patients who have COVID-19. 2 different research groups have presented information how these patients may develop ocular motility deficits and or oculomotor palsies. And even though the case number is not very high at this point, again, you got to think about this. People present with eye-related issues, and if they're asymptomatic, are not going to be sent to isolation or sent to the infectious diseases, right? They're going to be going to the neurologist, or even in this case, the ophthalmologist. By the way, the first doctor in China who sort of blew the alarm, blew on the COVID-19 was actually an ophthalmologist. So, so don't let the fact that these cases don't seem very high dissuade you, because it might simply be a case of lack of reporting. So in any case, how may we as acupuncturists help patients who are suffering oculomotor palsies, possibly as a consequence of having neurological dysfunctions from COVID infections. I need to briefly introduce you to something called a frontal eye field. And the frontal eye field, okay, it's we talk about the Brahman areas, right? It's located in Brahman area 6, so you can have a look at that in the map in a moment. And what happens is that this part of the brain is responsible for controlling rapid changes in your eyes in the left to right direction. It's called saccadian movements. So patients who have dysfunction in these eyes, in these areas of the brain, affecting this area of the brain, may manifest inability to have rapid eye movements. And this is also called contralateral horizontal conjugate gaze palsy. So if you recall the American paper showing you the 5 different patient cases, one of the symptoms that they had was gaze preference. Okay, it's because they are lacking the ability to see both sides, so they have a preference for one side. And now, how does this affect the parts of the brain that actually controls cranial nerves 3, 4, and 6 that actually is responsible for the eye movement? Based on tractology or connectivity studies, neurologists have found that the frontal eye field actually makes connections with the midbrain, where these cranial nerves connect the eyes form. So again, these midbrain structures and cranial nerves are too deep for us to affect directly, but for us indirectly through the cortical connections, we can have a fighting chance to affect oculomotor systems. So I'm going to show you my research about this. You're looking at the correspondence of the scalp and the cortex, specifically gallbladder 16. And what's really cool about this, and I love that when the east and west converge, gallbladder 16 in Chinese is mu chuang. It means eye window. Hello, the name is telling you that this point can do with vision, and that it actually corresponds to frontal eye field based on modern research is just too good to be true. Okay, so where is this specifically, this frontal eye field in humans? A lot of research in animals suggests that it's in Brodmann 8, but we now know that's incorrect. It's in Brodmann 6. And so where is that? If you look at the yellow dotted line, it's where the superior frontal sulcus meets the precentral sulcus. So here's the central sulcus, okay, where we divide the motor and sensory, and then you have the premotor area, or the precentral gyrus. Right in front of that, it's called the precentral sulcus, where the precentral sulcus meets the superior frontal sulcus. Okay, this is superior frontal sulcus. This one over here, although broken, is the inferior frontal sulcus. So in a case where the superior frontal sulcus meets the precentral sulcus, now the bird's eye view, superior frontal sulcus meets the precentral sulcus. This area is where Brodmann 6 or the frontal eye field is located. And we have a point, gallbladder 16, which is just right in this area. And if you thread it, if you're familiar with scalp acupuncture, along the meridian, you will cover this area beautifully. And therefore, you will be able to affect the frontal eye field and affect eye-related movements. I'm going to just finish up with the case that I recently saw of a stroke case. I tongue-in-cheek call it the case of stroke in the time of Corona. And this was an 86-year-old male patient who, in early April, he and his family cannot be sure exactly when, where he started developing slurred speech. Now, he has the risk factors such as hypertension and diabetes mellitus and other non-directly related symptoms, comorbidities such as frequent urination as a result of enlarged prostate. He's had a history of Bell's palsy in his 40s. Now, several weeks before he developed a stroke, he had some poor sleep. So it's unsure whether that sleep was related to, that's just a coincidence, or related to poor sleep having caused hypertension, poorly managed. But in any case, he was admitted to the hospital for one night, and because the symptoms was thought to already showing signs of, very fortunate man, already showing sign of improvement. He was discharged the next day. And which is atypical, actually. Typically, when you have a symptom of stroke, you are in the hospital for way longer. Not sure this is change in policy is dependent on the fact that there's some lack of resources and staffing during this time of COVID, that the patient, since it was not life-threatening, was sent back home. But in any case, in addition to slurred speech, he also presented with left-sided arm and leg paresis. And he felt extremely tired. Remember, one of the only symptoms that one of the 5 Americans that had the stroke were just lethargy, right? There's no other COVID-related symptom. This man didn't have any respiratory problems, fever, and as such, but it doesn't mean he's not positive, right? From all the research that we've seen so far. And the family noticed that ever since having a stroke, he seemed to have markedly aged, and just complaining about tiring all the time. He has a dark tongue, okay, dark purple tongue, indicative of blood stasis. That's the D-dimer coagulopathy that we talked about. Thick white curdle coating, which means a lot of phlegm, cold phlegm inside the body, okay, which is, we know cold also contributes to stasis, right? So the pictures are triangulating quite nicely. Unfortunately, so this is actually a family friend of my receptionist. And because the clinic's closed, mandated it closed because of public health policies, he's unable to make an acupuncture appointment with me or with anybody. So it wasn't until we all reopened on June 2nd, he was able to get his appointment. And so on the very first day that I was back on June 6th, he saw me for acupuncture. And to date, we've had 4 sessions so far. And I'm happy to say that the results have been quite favorable. After 1 treatment, he said that his left leg, which is the afflicted side, actually now feels stronger than his right side. Okay, so patient, maybe there's a little bit of a good patient and practitioner rapport there, maybe a little bit of psychological effect, but hey, I'll take it. But so far, there's no change in the arm strength just yet, which is actually expected. Those of us that have experience treating doing neuro rehab know that arm loss of function or paralysis is harder to regain than leg paralysis. Okay, but by the end of the 4th session, the patient actually left the treatment room without taking or quote unquote needing his cane. So presumably that is indicative that his legs feel so strong that he forgot that he needed the cane. So that's the latest case I can share with you all. I don't know for certain that it is a case of COVID, but I'm using extreme PPE precautions, and I'm suggesting that this patient go get tested just despite being asymptomatic. So I thank you very much for your attention, and if you have any questions, just message me. If you like this presentation, don't forget to tell your colleagues. Don't forget to let others know about it, and then and if you enjoyed it, show us some love. Thank you very much.